Hello, my name is Michael Breinin. I'm the president of the World Stroke Organization, and I'm delighted to welcome you to the WSO Members Forum. Every year on World Stroke Day, our global stroke community comes together to speak with one voice for stroke and to urge action on stroke from individuals and from our leaders around the world. This year, we are communicating against the backdrop of a viral pandemic, which has demonstrated that robust individual health and strong healthcare systems are fundamental for a functioning society. The world has also learned that when it comes to our health, we're all deeply connected. This connection shows that it's only by working together as a global community that we can hope to address the health challenges that affect us all. Each year, 14 million people suffer stroke worldwide, and 80 million people are living with the consequences of having suffered a stroke. The mission of the WSO is to reduce the global burden of stroke through more and better prevention, effective treatment, and long-term support. Therefore, I think the WSO Members Forum will be very influential and very effective in picking up the pace and influencing the change we need to reduce the burden of stroke on a global level. Thank you very much.
Thank you very much, Michael, for that warm introduction. My name is Sarah Belson, and I am the International Development Manager at the World Stroke Organization. Good morning, afternoon, evening to everyone. Thank you for joining our Members Forum today. This is the first forum of its kind, and we hope you enjoy it. Today's forum is a collaboration between the Education Committee, the Stroke Support Organization Committee, and the Campaign Committee of WSO. Your session facilitators today, Gord Gubitz, who is the Education Committee co-chair, and Monica Sani, the other Education Committee co-chair. I'd like to personally say a big thank you to them for all the support they've given to us in organising this forum. So I'll now hand over to you, Gord, to introduce our speakers for session one in our Advocacy Collaboration Cafe.
Well, thank you very much, Sarah, and good morning to everybody around the world. Friends, we're here together to talk about stroke care internationally, nationally, locally, and even within a single hospital or at the bedside. And it would be no surprise to anybody on this call if we said that the collaboration around the care of patients and the support of patients and their families is really essential in what we do. Collaboration is one way that we can learn from each other. And collaboration is key to ensuring that the advocacy work that we're all engaged in around the world has teeth, that it's effective, that we can get a hold of people and allow them to understand what it is that we're doing. Collaboration is also crucial for harnessing the expertise of people that we work with in terms of our stroke stakeholders, be they researchers, be they academics, be they clinicians at the bedside, be they families, friends, persons with lived experience. Everybody involved in stroke care benefits from collaboration. And I think that stroke is one of those disorders that really brings that to the fore when you think about all of the disease states that we're faced with every day. Collaboration also is really important in strengthening the message. If we get together, we can achieve great things. And I think we have three wonderful examples of that this morning. In this session, we'll hear examples of collaboration from around the world, really from Nigeria, from Japan, and Brazil. So first, from Nigeria is Rita Melifonu. She's a nurse consultant in stroke rehabilitation and the chief executive of the stroke support organization Stroke Action. In 2019, Rita was named a leading stroke entrepreneur by the Ashoka Foundation. Her interests include stroke advocacy for policy change, grassroots stroke awareness and prevention, rehabilitation, and psychological support. Rita is a member of a number of groups and organizations, including the NCD Technical Working Group of the Nigeria Minister of Health, the WSO Board, the OSCAL Research Group, the WHO Stroke Development Group for a package of rehabilitation interventions, the African Stroke Organization, and the International Stroke Rehabilitation and Recovery Alliance. That's a lot of things. Our second speaker is from Japan. Hirofuma Nakayami is a medical doctor and executive director for the Japan Stroke Organization, which is a WSO member and has representation from the WSO board and SSO committee. Dr. Nakayama has been active in the forefront of lobbying activities for improved stroke legislation in Japan for over 10 years. And finally, Dr. Sheila Martins is an MD and PhD from the Universidad Federal de Rio Grande do Sul, head of neurology and neurosurgery, and the president of the Brazilian Stroke Network. She's also president of the Ibero-American Stroke Organization and has been the vice president of the SSO of the World Stroke Organization for the past 2 years. And Sheila will be speaking to us today from Brazil. So next, I believe that Mission Control is going to play a video describing the advocacy work of these three fine individuals, and then we'll pull it all together and have a wonderful conversation. So back to you.
My name is Rita Melefomu. I'm the Chief Executive of Stroke Action Nigeria. I'm going to talk to you about my advocacy goal for Nigeria, who I worked with to achieve this goal and why, the results I achieved, and one or two key lessons. My advocacy goal for Nigeria is for the Federal Ministry of Health to have a budget allocation for stroke care in Nigeria by 2018. I set this goal at the World Stroke Congress in Hyderabad in India in 2016, when we had the first stroke advocacy toolkit workshop in Hyderabad. So if we think about the context in Nigeria at the time, we did not have any financial allocation for stroke care at all. We did not have a national stroke strategy. We did have an existing NCD strategy, but there was absolutely no stroke mentioned on the strategy. So my objectives were to try and see how we can review and update the existing strategy so that it will include stroke, knowing fully well that any policy in Nigeria will not fund any item or intervention that is not contained within the policy. I also wanted to see that if we can review the strategy, how can we develop a work plan and the budget for the reviewed strategy, and then get a ministerial and presidential sign-off for the strategy together with the work plan and the budget. So how did I work on this, and who helped me? Prior to this, I advocated to have a collaboration with the Federal Ministry of Health so that we can raise the quality of stroke care in Nigeria. As a result, we signed an MOU, Stroke Action Nigeria, with the Federal Ministry of Health, with key objectives, 6 key objectives. And one of the objectives is to set up a Nigerian stroke reference group. This is a multidisciplinary reference group that includes the chairman or president of all the health and social care professional groups in Nigeria, like the Medical Association, Nursing Association, Therapy Association, etc., etc. Now, the Nigerian Stroke Reference Group lives within the NCD department in the Ministry of Health, and it's an advisory body to help the Federal Ministry of Health to make policy decisions on stroke services development. So I sit on the Nigerian Stroke Reference Group, and I am the secretary of the Nigerian Stroke Reference Group. So we convened a meeting to review the existing NCD strategy. We've already agreed to work with the NCD team in the Federal Ministry of Health, and as a result of that, we have a stroke desk officer. The review identified that definitely and confirmed that we did not have any stroke mention in the policy. We engaged the media to advocate and publicize on what's happening in stroke care in Nigeria. We had access to the minister because of the MOU, and we can set up a meeting to meet with him and discuss the issues we are having. When the NCD strategy was reviewed, it was then updated to include stroke. The World Health Organization Regional Office was involved in this, and the multi-sectorial action technical working group was set up by the minister, and I was part of that technical working group. So what this technical working group has done is to make sure that the NCD strategy is reviewed, is now contained stroke. It is now called the National Multi-Sectoral Action Plan for the Control and Prevention of NCDs in Nigeria, including stroke. It has been signed off by the Honorable Minister of Health and the President, and this was done in September 2018. The budget has been allocated for it. And the funding is disbursed to people with NCD and stroke through what we call the Basic Healthcare Provision Fund. And it's allocated through the National Health Insurance Scheme or the state level health insurance scheme. At the moment, a high-level technical working group on NCD has been set up by the minister, who you can see in the picture wearing a black coat there, to monitor the implementation of the technique of the NCD strategy and also identify gaps. And I sit on the technical working group. So, have we achieved my goal? Yes, we have. We don't have a stroke strategy for Nigeria, but we have an NCD strategy that contains stroke. So therefore, the key messages for me is to make sure that in setting your advocacy goal, you identify a clear need backed by evidence. You have to develop a SMART goal, set a time plan by which you can achieve your goal. If you are looking for setting your goal, your advocacy plan, you go to the WSO's Global Stroke Advocacy Toolkit. You can Google online, it's there, and you can get your template to help you to set your goals. And then you can work with people, form alliances, collaborate, joint work, and partnership. This is very key. Engage decision makers and the media, and that way you will get your advocacy to and your advocacy goal achieved. Thank you very much. Thank you.
First, I'd like to thank you for giving me an opportunity to share our experiences of making and executing the Japan Basic Act on CVDs, namely Stroke and Cardiovascular Disease Control Act. Today, I would like to talk about what is the Japan Basic Act on Stroke CVDs and how we have advocated for that. We made this law because stroke is the fourth leading cause of death and the first leading cause to become bedridden in Japan, and the expenses related to stroke and cardiovascular disease account for the largest proportion of health expenditure in Japan. Goal of this act is to control stroke and CVDs so that the healthy life expectancy is prolonged and reduction of the burden of stroke and CVDs. Overview of this act. Government make basic plan to promote stroke and CVD control program, and each prefecture makes their own prefectural plan to promote stroke and CVD program, and national and local governments, medical insurers, healthcare and welfare workers, people share responsibilities for the plan, and the plan is reviewed at least every 6 years. Basic measures. First, citizen education on prevention and appropriate action at onset. Second, improvement of local emergency transport and medical system. Third, improvement of local medical facilities. Fourth, improvement of the quality of life of patients. Fifth, improvement of the coordination of relevant professionals. Sixth, nurturing of relevant human resources. Seventh, improvement of information collection system and consultation support system for the patients. And finally, promotion of research. Now, let me explain how this law was made. First, we started at Stroke Control Act. In 2008, we made ad hoc committee participated by patient groups, MDs, nurse, therapists, and journalists for exploring stroke control. In 2009, we released Stroke Control Act draft outline, and in the same year, we started Enactment Promotion Council for Stroke Control Act. We gathered petition of 182,000 people, which resulted in submission of Stroke Control Act by Diet members in 2014. But unfortunately, it was discarded. And since some Diet members were against this law, we couldn't let them resubmit it again. So we changed our strategy. We added CVDs as a target along with stroke, And we formed lobby organization for Stroke and Cardiovascular Disease Control Act, which was participated by stroke and CVD's relevant patient groups and specialist organizations. And in 2018, Stroke and Cardiovascular Disease Control Act was approved. So how have we advocated for it? We formed lobby organization consisted of patient groups, relevant health professional organizations, labor unions, individuals, and we did lobby activities through petitions, visits and telephone calls to Diet members, and rallies inviting Diet members. Key messages. The participation of stakeholders in making and in lobby activities of the law is necessary. The inclusion of other diseases, CVDs in this case, which share the same risk factors in the target of the law, is effective for gaining power for the legislation. But in case of inclusion, programs unique to stroke should not be played down. Thank you for your attention.
Hi, I will talk about establishing hyperacute stroke care in Brazil. Brazil, we have more than 200 million inhabitants with huge disparities. Public health assistance paid by the federal government, only 20% of population have additional private health care insurance. 80% of stroke patients are assisted in public health care, and we have one only national pre-hospital number, 192, called SAMU, that cover 85% of the population. We started the organization, this stroke care in 1996 with TPA approval by the FDA with the foundation of Brazilian Stroke Society. In 2007, we had 35 stroke centers created by local efforts from stroke neurologists. Since 1996, the Brazilian Stroke Society, the presidents tried to convince the Ministry of Health to implement acute stroke care in Brazil, but they had a lot of arguments for not organize acute stroke care. We have a lot of health priorities in Brazil, but how come stroke was not a priority if stroke was the first cause of death? It's not safe to treat patients with TPA in our emergency room that were overcrowded. We don't have enough beds in intensive care units. We don't have enough space to build stroke units. We cannot do CT scan in a short time, and we cannot treat patients in this short time. We show that with small areas inside the emergency room, combined areas to treat acute stroke patients and myocardial infarction, called vascular unit, we can safely treat patients with TPA in a short time, and we decrease the needs of intensive care units beds from 17 to 10%, and we decrease disability and mortality caused by stroke. The other excuse, TPA is too expensive for Brazil healthcare budget. We performed a cost effectiveness study showing that we decrease the cost and save money after the second year after treatment. And the other question, we need a clinical trial of thrombolysis in public hospitals in Brazil, and we didn't do that. So in 2007, I was invited to talk in National Congress of Urgence and Emergency of the Ministry of Health. And I had the opportunity to be heard and to show what we did and answer one by one their concerns. It was a great opportunity, and if you have it, you should use it very well, be objective, show local results or results from similar countries, propose objective solutions, how to do it, and offer your support to do it. This was the situation, 35 stroke centers with more than 1,000 thrombolyzed patients with good results. And when I finished my presentation, I told them that we had a dream as Brazilian stroke neurologists to implement acute stroke care in the whole country to give the best treatment to the whole population. When I finished my presentation, the coordinator of Urgence and Emergency of the Ministry of Health stand up from the audience and told to the audience, I am the new coordinator of Urgence and Emergency of the Ministry of Health, and together with Dr. Sheila, that we didn't met before, we will implement the acute stroke care in Brazil. And he really did. He invited me as advisor of the Ministry of Health to create a national program for stroke and implement a pilot project. So for this, we put together our Brazilian stroke neurologists and create the Brazilian Stroke Network with the mission to improve assistance, education, and research in stroke, and the first action to develop and to implement a national stroke project together with the Ministry of Health, to work with them, but independently. I visit in person 20 out of 26 states, 90 hospitals, evaluating the situation of stroke care in the country and meeting regional health authorities. The organization in region, the key for the success, to know in person our reality and to identify a champion to coordinate the development in each region. So in 2012 was published the National Policy for Stroke with approval of TPA in the public health system and creation of stroke centers with stroke units and approval of line of care. We create an educational teaching course. And this was the situation in 2008. That's the situation now with 109 stroke centers, but we have several gaps yet. And for this, we create a telestroke program. We validate a smartphone app with low cost for telemedicine. And we validate for thrombolysis in acute stroke care. Now we have 12 hospitals with this method treating acute stroke patients. And we perform a clinical trial for thrombectomy in public health system. In Brazil, the first study in a developing country showing that thrombectomy is effective, cost-effective, and is feasible the implementation in a developing country. We create a Latin American stroke ministerial meeting to work together with other countries. We signed the Declaration of Gramado with the commitment of health managers to implement the best evidence-based strategies for treatment and prevention of stroke. And we launched 2 weeks ago the certification of stroke centers in Latin America based on the roadmap of World Stroke Organization with 10 countries together, 70 delegates from each country, 70 delegates from those countries, 400 people connected discussing the implementation of certification of stroke centers. Thank you.
I think we're live. Can everybody hear me? Rita, are you there? It's nice to see you. Good morning, Hirofumi. Good morning, Sheila.
Hi, morning.
Good morning. And for some it's afternoon, for some it's evening. This is incredible. I'm just having now my morning coffee along, hopefully, with many people in the audience. So thank you all for agreeing to be part of our advocacy forum and for taking part in this very unusual format. Where we're trying to really expand technology and allow this to happen. I should mention just before we get started, because people are now asking questions in the chat that we'll get to, is that thus far we have representation from Nigeria, Japan, Brazil, Canada, Cyprus, the United Kingdom, Denmark, Singapore, South Africa, Italy, and Ghana. And so really an international sort of perspective this morning. So you've dealt with collaboration a little bit. Collaboration obviously is not easy. And what you've shown us are the upsides, the really wonderful things that can happen when things go well. I'm wondering if you could think about one specific challenge that you met along the way and how you dealt with the challenge. I'm thinking, Hirofumi, maybe you could start, because in order to make your strategy work, you had to play with the heart specialists. So what did that look like? How did you get them engaged to work with you?
Actually, we were the front runner, and we had a very big problem because some diet members were against the basic act for stroke only, because they were afraid of having too many basic laws for each disease. So we had to show a big one disease, including stroke and cardiovascular diseases, because the cancer is the first leading cause of death in Japan. And if we put stroke and heart disease together, that corresponds to cancer. So the people now understand the importance of this problem. So to persuade people, we needed that. And also from the cardiologist side, they needed stroke because, as you know, people die from heart disease very often, but the cause to become bedridden is stroke, not heart disease. After intervention, they become active again, but after stroke, people suffer from sequelae. So coming together, they gain more power. So we both had the merits. But the problem was the stroke patient groups, they were afraid of putting together because after putting together, the unique problems for stroke will be forgotten. They were afraid. So some patients were against the strategy change. So we had to persuade them the merits of coming together and gaining power and having more impact for the society. And we also made special consideration for the stroke patients by adding special mention in the act. The government should take care of the stroke patients who suffer from sequelae. We put that article in the act at the end of the act. So we tried to persuade them and succeeded in a way.
So there we have it, working together, more collaboration. Rita, in terms of challenges that you've faced, you mentioned at the very beginning of your talk that you started with absolutely nothing and you had no budget. I've got a comment here from Michael Anchoro from Nigeria as well, who says the issue at stake is that there's no money, there are no funds. And so how do you think effective advocacy can leverage increased funding from the government? There's an easy question for you.
Okay, so when we started, thank you, Michael, for that question. When we started, there was absolutely no budget for stroke because stroke was not included in the policy. And if it's not included, nobody's going to allocate any funding to it. So through advocacy, stroke is now within the MSAP, which is the Multi-Sectorial Action Plan. And it is accessed through the National Health Insurance Scheme. So I'm happy that Michael asked this question because a lot of people don't take it seriously. Before, people that work in the formal sector, the health insurance contribution is taken directly from their salaries, but people in the informal sector very rarely pay for health insurance. So this is an opportunity to find your local hospital and register for the basic healthcare provision fund. So if you don't have it, you'll not be able to access health insurance in Nigeria, and the stroke funding is embedded within the health insurance. I hope that is helpful.
Okay. Sheila, you went from a small local challenge to now a Latin American challenge. Can you tell me, if you look back on it, is there a specific challenge that you thought might defeat the whole process that you had to overcome to make your initiative a success?
Yeah, I think the first challenge is to be heard. They need to hear us and to trust in our reasons to start the organization of stroke care. And after this, we start step by step, and each step lead to an improvement in stroke care in Brazil. So first we show our local effort and the local organization. After we show them that we are working together with local health managers, and after this, we create a national program. So, and now we are putting together the other Ministry of Health to work together, so we can show good examples and good success examples to improve stroke care across all regions, and now health managers are working together in Latin America.
Right. So I think perhaps a common theme around this is recognizing that people across all of our countries are working in their own hospitals and their own universities as small groups, providing excellent quality stroke care, the best quality care that they can. And it's about linking with each other. So it's getting the prefectures in Japan to speak together. It's getting the various different groups and areas in Nigeria, in Brazil, to have that the collaboration, the speaking together. We're compiling some questions from the audience. I've just been told that Portugal is here, as well as Mauritius has joined, and so welcome to both of those groups. Do you think and this is a question for everybody. Is stroke advocacy a full-time job? How do you get the rest of your work done when you're busy changing the world? So, as an example, where do I start? Is it a full-time job for me?
Yeah.
What do you think, Rita?
Well, it looks like a full-time job because you're a clinician. You're a clinician, doing everything you have to do, and everybody knows your phone number. I mean, I get calls from all over the place, and I think, how did I get my number? I found it on the internet. So it looks like a full-time job. The important thing is collaborating and forming alliances. Okay, like when we got started, we had to have access to the Minister of Health, and you don't just go to the Federal Ministry of Health and walk into the Minister's office. So we had to find someone, to the ambassador to the UK had to write a letter to the minister to see us. And that's how we got to see the minister.
So can you tell me, can we unpack that story a little bit? So how did you find the ambassador to the Nigerian ambassador to the UK? They're not in the phone book, are they?
No, they're not in the phone book, but I'm privileged to be British. So I just walked into the the Nigerian embassy in London and demanded to see the High Commissioner. So,
okay.
And the ambassador, and I got a letter and a phone call instantly because he is a doctor and he was very happy about what I'm doing to advocate for stroke care in Nigeria. So the second thing is working with doctors. I'm a nurse. If you're a lay person and you're not a doctor, even if you have access to the Ministry of Health, nobody listens to you. So I have to form an alliance with all the Nigerian doctors that are in UK. And in fact, they contributed money and their president came down to Nigeria with me to see the Minister of Health. So that's how we got started. So, you have to work with people. You have
All
to
right. Sheila Hirofumi, do you have anything to add to that?
Yeah, well, I work a lot and advocacy looks like a full-time job, but it's not. I'm teacher in university. I'm head of neurology and neurosurgery. In a private hospital. I have round with residents when we finish this meeting now, and I have my outpatient office, so I have a lot of job, and I have this full job that is advocacy in all Latin America. So it's very hard, but it's a pleasure for me to work on this. So really, I think by example, working day by day with patients and residents, you can show them that you can work and you can change people's lives working in advocacy too.
Okay. Hirofumi, any thoughts?
Yes. In Japan too, the active members of Japan Stroke Association, they are volunteers. And so they are working at hospitals, and I myself is working at my private clinic. And we use their marginal time after work or during the work. We do communication using internet, and we use weekends to do the public education, holding events, and so on. So it is quite a voluntary work in Japan too.
But it does sound like full-time voluntary work for some people. Huh? So you don't get something for nothing. So no, what can we offer to get other people to collaborate with us? What's in it for them?
I myself is a doctor, and I always had problems because, of course, I wanted to prevent stroke, not only seeing the aftermath. So prevention was very important. All the doctors know that. But since they are staying in medical facilities, they do not have contact with citizens before becoming ill. So their sincere wish is to tell people how to prevent it. So their actual professional wish, I should say. So it is a very big motivation for them to do the voluntary work, I think.
All right. So thinking about volunteers and thinking about people who are affected by stroke, my mind immediately turns to people with lived experience, stroke survivors, their families, their friends, because stroke affects not just the individual. Looking back at the work that you've done, what sort of engagement, what sort of involvement have stroke survivors and people with lived experience had, and how has that helped? Has it allowed the process to move forward? What do you think, Sheila?
Yeah, I think they are very important. When we start, In 2008, we found the Brazilian Stroke Network that was very important. And in the social media, we start to invite people to be engaged. So health professionals, patients, and we start to stimulate the organization of stroke support organization. And now they are working hard together with us in the World Stroke Day. They were all the time together with us, and patients and families. The testimonial is very important to engage more and more and more people. So I think is the way to go, and to stimulate people to work together as a volunteer.
And when you speak about testimonials, are you thinking written testimonials? Are they audio tape? Do you have your stroke survivors coming with you to meetings with government members? What's the breadth of experience that you've used to make that happen? That's a question for everybody.
Okay, in Nigeria, what we've done in the absence of stroke units, we have the stroke support organization as Stroke Action. And quite quickly, we sort of engaged other health professionals to have a multidisciplinary life after stroke center in the community. So that was something that the government wanted to see, that somewhere that the stroke survivors can go to. So when they're discharged to hospital, they come to us and we support them with their rehabilitation. Now, what we began to see is that stroke survivors are getting younger and younger. Because they have stroke, there's no legal protection, they lose their job, they're unemployed. So we started very early to develop a role for them as stroke ambassadors, who can then volunteer and receive a stipend. We advocate for them. Those can go back to work, especially teaching, and those that are self-employed can go back to their work. And we have now developed what we call the Stroke Entrepreneur Program, where we support them to get involved in micro enterprise. So that's what we've done in Nigeria.
Okay. What about in Japan? How have stroke survivors influenced the outcome?
The voice of stroke survivors and family members are very strong compared to professionals. For example, if you go to the Diet member's office, they do not like doctors, but the patients are welcome. They like patients, and they listen to them. So when we do the lobby activities, we often go with the patient groups together. Also the labor unions, they are very interested about reducing the workers to become stroke, because because of the benefits of the workers for themselves, and also the insurance. The labor unions, they have health insurances, and for the benefit of insurance, it is very important to reduce stroke. So they are very collaborative in a way, and their co-workers who had stroke have very important message for them to be careful not to become stroke, and why they are suffering, how they are suffering after having stroke. So it is very important for the lobby activities also, and also for their citizens too. Citizens listen to the stroke patients, because real voice is more persuasive than doctors, and often doctors are not good at explaining very simply and easily. So we stroke survivors, we need them to do the social change, I think.
Wonderful. So we're going to change tack a little bit. We've had a couple of comments about one from Monica Saini, my co-chair for the Education Committee. What are your tips to engage and convince politicians? They're tough nuts to crack, politicians. And I think the idea behind that is that as soon as you identify a politician, there are many different people that they're speaking to who all want the same thing. We want you to tell us that our disease state is the most important, etc. So I'm thinking about Hirofumi's collaboration with cardiovascular disease and heart. But what other things can you do, apart from knowing who the British High Commissioner is, or whatever, to get the ear of the politicians?
Yeah, I think one important thing is trying to get the user voice inside the Ministry of Health. So for instance, within the multi-sectorial action plan, we now have stroke survivors and people with NCDs, cancer, that are members of the technical working group making decisions. So that is really important. And they're also engaged as national NCD ambassadors, that they participate in meetings and making decisions. So they tell you how it is for them and for a lot of other people living with NCDs. So the politicians do have to listen, because they have signed off the NCD policy, they have set up the technical working group, and people living with NCD are part of it, and they accept the decisions that are made. So that is really, a hot point there, that people with NCDs should get into the Ministry of Health and get involved with the technical working groups in policy decision making. So that's really important.
So embed yourself within the political system.
Yes.
Yeah. What about you, Sheila? How did you get the ear of all of those people and get to be on the commission?
Well, several times, because the Ministry of Health changed a lot in Brazil, So when I organized the first Latin American ministerial meeting, we changed 4 times the Ministry of Health. So I convinced the first one, he was fully together with us, but they changed. And when the new minister starts, we have only 1 month to the ministerial meeting. So I discovered that the Ministry of Health would be a meeting in a countryside city. I bought a flight ticket, went there, and he was a lot of politicians around him. And hi, I'm Sheila Martins. I'm from Brazilian Stroke Network. I need you for a meeting in 1 month, a very important international meeting. And so I think this is very important. Schedule a meeting with Dr. Sheila. So several times I have to do this, introduce myself in middle of several other, because when the minister sometimes change everybody around, and I need a short time to show them the job and the importance of the job, and usually I can convince them to work together with us, showing by example what we are doing in Brazil.
Sheila, I don't think anybody would ever say no to you if you approached them and said, I need a meeting with you for 10 minutes, just for 10 minutes. It's fantastic. We've had an interesting suggestion from Urvashi Gopal from Mauritius, and I'll read it for you. It said, wouldn't it be useful if stroke advocacy was embedded in the undergraduate curriculum of health professionals, including doctors, nurses, physios, OTs, etc.? That might help. So not really a question, but I'm wondering, is that a direction that you have thought about or used in your own advocacy work?
Well, we use that in Nigeria, because I said earlier that we have stroke ambassadors. Our stroke ambassadors are not only stroke survivors. So we have health workers, doctors, nurses, therapists, pharmacists, media people, and we train them. We've developed a training program that we call Knowing Strokes, to tell them a little bit about strokes, so that they're stroke aware, and then tell them what to expect as their roles as stroke ambassador. And we have over 85 of them across Nigeria in different states, and they advocate for stroke care in their workplace. They have to choose the area they want to work, whether it's in their workplace or their community or in the government. So that's what we've done in Nigeria.
Fantastic. So it becomes embedded in their training. It's something they think about as they're planning their patient care.
Yeah. Well, I think it's very important. I try always to put in the curriculum, not officially because it's not in the curriculum, but some students cannot understand the importance of this. But I always try to engage them, and I think will be very important, because it's not only the technical aspects that are important in our job. It's very important to know how to join people, to stimulate and to work with governments. I think would be very important.
Fantastic. Hirofumi, last word on that question. Undergraduates and residents.
Yes, of course. The stroke patients, they are very good at influencing undergraduate students, but also the doctors, because I should say the doctors, they see from their own point of view but we are not very understanding what patients are suffering from. Mm-hmm. So we have to hear from them what they are suffering. Subjective voice is very important in a way, and medical education is always trying to become objective. But of course, you can't. Of course, if you experience stroke, so you know the boss. But most of the doctors do not experience stroke, and just imagine how patients are suffering. So we have to hear them and feel them. to understand the problem, I think.
There you go. So you will not believe this, but we are rapidly closing in on the end of this session. It could probably go on for another couple hours. I have one final question for each of you. What I'd like you to do is, just in a few minutes, if you could go back in time and give a piece of advice to yourself when you were beginning your journey of advocacy, what would your piece of advice be for yourself? Rita, would you like to start?
I think
Just put you on the spot.
Seeing the lack of engagement of nurses in stroke care in Nigeria. When I first got started, instead of going to the doctors, I should have gone to nurses. You know, no offense, but
None taken.
We would have achieved a lot more in terms of grassroots stroke advocacy, starting from bottom-up approach and getting there. But I came from a top-down approach, and I don't think that was the best thing to do.
All right, so start with the nurses. Hirofumi, what would your advice to yourself be?
Looking back, I think we should be more collaborating with the patients and families, for example, to take them to their seminar for the citizens and let them speak by themselves, not only explaining the medical explanation for prevention and an act fast message, but the real voice was more effective. Looking back, I think so.
All right. And Sheila, final word to you.
Well, I would do exactly the same because it worked very well, and working working together with people that think like you, we create a solid and strong group to work together, but independently of the government. So it was the Vladimir Hashinsky advice for us to create a network to work together formally, but independent of the government, because you can do everything very well.
Right. And I think one of the phrases that you used in your response was like-minded people. And I think what we have today is a collaboration of like-minded people from all around the world and here on the screen today. So what I'd like to do in closing out this Advocacy Cafe is to thank you all very much for taking your time, putting together some wonderful presentations, and being so totally engaged in the process of educating the world about stroke advocacy. So thank you on behalf of the people that you're working for. I think I'm going to hand over now to Sarah once again. So back to you, Sarah, in Mission Control.
Okay, so just to kick us off, there's a number of tools that we really feel that can support your stroke advocacy. So starting off with the WSO Stroke Care Guidelines and Roadmap, this outlines care that needs to be in place, taking into account the context in which you're operating. And it provides a framework that can be used locally to implement, monitor, and evaluate stroke services. The tool is available on our website, and it's also in the delegate bag. We also have the Advocacy Toolkit that was developed with a number of our WSO members, both people affected by stroke and stroke professionals. And this is a guide for advocating about stroke in your region. And it suggests tools and tactics to inform your advocacy. And then a document that many of you will be familiar with is the Global Stroke Bill of Rights. And this is a tool that can be used by individuals and organisations to communicate with stroke care providers and governments about what people affected by stroke think are the most important issues in their stroke recovery. And we also have developed some guidelines for using the Global Stroke Bill of Rights in your advocacy. And then, as I previously mentioned, this year we launched the Stroke Connector Hub. So this is an online hub for WSO members. It's a membership benefit. It's an interactive space for members to connect and exchange knowledge in regard to stroke support and advocacy. There are a number of tools and resources on the hub, and we want to continue to add to that database of resources. And while some of those resources are from WSO and from our partner organisations, we also encourage our members to suggest resources that they're using in their context and perhaps some insights and experience about what has worked well with those resources. And then finally, a couple of policy briefs that we would, and a fact sheet that we would like to highlight. So the Acting on Stroke and NCDs policy brief explores the impact of stroke in society, highlighting the need for awareness on how to prevent and treat stroke. And Driving Action on Circulatory Health, the white paper, identifies a range of priority actions that could inform stroke advocacy. And this is from the Global Coalition of Circulatory Health, of which WSO is a member. And then the Global Stroke Fact Sheet provides an overview of the best available scientific evidence to give reliable and up-to-date data on stroke and its impact around the world. And these tools are available on the WSO website in the Publications and Resources section. And we hope that you find them useful and that they are resources that can inform your stroke advocacy.
Hi, I'm Monica. I'm one of the co-chairs of the World Stroke Education Committee, and I'm very, very privileged to welcome you all to this session on policy advocacy, evidence and impact. For all the people who were here for session 1, welcome back. And you heard from 3 absolutely fantastic rockstar speakers, Rita, Hiro, and Sheila. And what you heard about was how they've gone about doing their advocacy work. So what is advocacy? Well, for the World Stroke Organization, what it means is all the activities that influence change in practices and attitudes of organizations, institutions, as well as governments. And what we're looking at is influence change in policies that are actually impactful. What we need for these changes is, of course, you need to influence people, you need evidence to influence people, and you need to understand how to make maximum impact. So in this session, we have 5 absolutely brilliant speakers who will be talking about gathering evidence and making impact in very, very different contexts. I have 5 speakers to introduce, and their CVs are extremely impressive and very long. So yes, I'm going to be reading from a script. The first speaker is going to be Jess O'Hara. She's a research assistant on an NIHR-funded global health research program on stroke in Sierra Leone at King's College London. She's an experienced program coordinator. She's working internationally with expertise in project management, community engagement, and communications. Jess is a graduate in global health and social medicine, and her specific interests lie in health systems strengthening in low and middle income countries. Our second speaker will be Dr. Patrice Lindsay, who will be presenting along with Manuel Arango. Dr. Patrice is Director of Health Systems Change at Heart and Stroke Foundation Canada. She leads strategic directions for systems change and knowledge translation across Canada. She's also the senior editor for the Canadian Stroke Best Practice Guidelines. And for all who've read the World Stroke Organization Global Stroke Guidelines and Roadmap, she's the lead author on that as well. Manuel is the Director of Policy and Advocacy for Heart and Stroke Foundation Canada. He oversees the foundation's policy and advocacy efforts. He's also a media spokesperson for the foundation. He's chaired various coalitions and a board of directors as well. He has a master's in experimental psychology and a master's in health administration. So I'm sure he has a lot to tell us about how to go about influencing people. Elizabeth Suka, she's managing editor and global healthcare editorial lead in the Economist Intelligence Unit's thought leadership team. She's been a journalist and an editor for more than 15 years, and she brings with her a very wide experience. She's been covering healthcare policy, R&D, and science for medical journals and UK newspapers, including the BMJ as well as the Guardian. Now, before she joined the EIU, she was the deputy news editor at the Royal Pharmaceutical Society. She ran the news analysis desk, and you might have heard her comment on healthcare issues on BBC Radio. Our last speaker will be Arlene Wilkie. She's the Director General of Stroke Alliance for Europe, and she leads and oversees the delivery of all safe activities and projects. She has a huge experience of alliance building, especially in relationship to policy development and implementation. She's held various leadership positions in a number of health-focused organizations over the past 20 years. And in her current role as the SAFE Director General, she also co-chairs the Implementation Committee of the Stroke Action Plan for Europe.
Thank you for the introduction, Monica. Good afternoon, dear attendees. I am delighted to have been invited to present in this session on policy advocacy. As Monica mentioned, I am a research assistant working on an NIHR-funded global health research program on stroke in Sierra Leone at King's College London, and that's CISL for short. Led by Professor Catherine Sackley, the group was launched in 2018 and is due to end in 2022 with the aim of improving outcomes for stroke patients in Sierra Leone. So today I'll be sharing our experience of policy advocacy. And to start, I'd like to give some contextual background on Sierra Leone and the CISL program. Sierra Leone has a population of just under 7 million people, ranking 181st out of 189 countries on the Human Development Index. There is an out-of-pocket health system with a critical shortage of doctors, nurses, allied health professionals, and specialists. Connaught Hospital is our research site, and that's Sierra Leone's principal adult referral hospital. Stroke is now the leading cause of death and disability from non-communicable diseases in Africa. It's experienced earlier in life than in developed countries and affects working parents with devastating financial consequences for families. In terms of what's known about the current stroke care pathway in Sierra Leone, CT scans are rarely performed, there's no thrombolysis or neurosurgery facilities, variable oxygen supplies, no stroke unit, no multidisciplinary team working, few rehab professionals with only 6 qualified physiotherapists in country, and minimal equipment and no community follow-up services. The CISL program aims to improve outcomes for stroke patients and families by bringing together world-leading stroke research and care expertise with an existing award-winning clinical partnership in Sierra Leone, and that's KSLP, the King Sierra Leone Partnership, established in 2013. The program is split across 5 work packages. The first is study management, capacity building, community engagement, the stroke register, and then a nurse-led intervention feasibility study. Now, at the start of the program, there was no NCD strategy nor stroke policy in Sierra Leone. And in the absence of data and local strategies to build on, CISL tasked itself with establishing a prospective hospital-based register to provide baseline data for future interventional studies, evaluate hospital care, identify risk factors, as well as ascertain mortality and morbidity of stroke in Sierra Leone. So what is advocacy? The World Stroke Organization have a really useful toolkit called the Advocacy Toolkit. A link will be provided at the end of this presentation. And they define advocacy as activities that bring about change in policies, practices, and attitudes of stroke organizations and institutions about stroke. At a global level, there's been great progress on stroke policy, and the Advocacy Toolkit brings our attention to 3 key documents. The first being the World Health Organization Global Action Plan on non-communicable diseases, and that includes addressing the global burden of stroke. And then the World Stroke Organization have developed 2 key documents, the Global Stroke Bill of Rights, identifying aspects of care that are important for stroke survivors and caregivers globally, and then the Roadmap for Quality Stroke Care, outlining the care needs that need to be in place in different parts of the world. These documents combined identify important aspects of care that we can expect to see across the globe, as well as showing global support and consensus on what needs to be in place for stroke. But then how do these translate in local context, in ensuring that the best practice, evidence-based stroke services are provided? There are several challenges in doing this in LMIC contexts. Policy advocacy is the spearhead to change and is more than just presenting data to decision makers. And we as researchers or policy advisors need to also understand the barriers and enablers of change and navigate them. And common challenges identified in LMIC policy literature include competing priorities, lack of awareness, lack of research and training capacity, limited financial and human and material resources, and inadequate knowledge and skill levels. So what are CISL's advocacy goals? This diagram gives a basic illustration split across the work packages. So in terms of input, we have the capacity building, the community engagement, the register, and the nurse-led interventions feasibility study. The stroke register is a major step towards defining the problem and driving quality improvement and laying the foundations to evaluate health system changes over time. However, as I previously mentioned, advocacy is more than just presenting data to policymakers. And it happens at different levels, at the local, regional, national, and international levels. And the World Stroke Organization Advocacy Toolkit notes that the most successful advocacy joins up the different levels of influence. And in recognition of that, the CISL program value community engagement and capacity as important components of policy advocacy in raising awareness and supporting the evidence base. So when the CISL program started, there was no strategy nor policy on stroke in Sierra Leone. And an early success of the CISL program has been our work in advocating for the inclusion of stroke in the country's first NCD strategy. And this has been done through the preliminary stroke register findings combined with effective community engagement. So this slide summarizes the preliminary data. We have high in-hospital mortality rates, high all-cause mortality rates at 90 days, and high prevalence of hypertension among registered participants. So equipped with this preliminary data and through effective community engagement with key community stakeholders such as religious leaders and officials at the Ministry of Health, and the setup of a service user-led reference group, which has over 60 survivors and caregivers, and that's called the CISL Stroke Survivor Group, and involving them in identifying local priorities and doing all of that alongside the registered data, we've been able to advocate for the inclusion of stroke in the first NCD strategy of Sierra Leone. So here are some examples of our ways to raise awareness and support our evidence base in advocating for policy change. So we've been involved in World Stroke Day activities. We were involved this year, we were involved last year. We publish articles on stroke survivor experiences of stroke in Sierra Leone, and we have local TV and radio coverage on the burden of stroke, and that's led by in-country physicians and research assistants, and engagement with members of the Ministry of Health, such as Dr. Santigi Cisse, who is the lead author of the strategy. So to summarize the sort of pathway to impact, we have the preliminary stroke register findings and community engagement activities, which have improved public awareness and political buy-in, leading to the inclusion of stroke in the national NCD strategy for the first time. Thank you very much for your time today, and I look forward to any questions that you may have. Please do follow our Twitter page, and the link will be provided at the end of this presentation to keep up with our regular updates on our work.
Good day and welcome to the Stroke Support Organization Members Forum. I'm Patrice Lindsay, and I will be here with my colleague Manuel Arango, presenting on behalf of the Heart and Stroke Foundation of Canada. Neither Mamie or I have any conflicts of interest to declare for today's presentation. I'll start by giving you some overview and information about our systems change work and how we've implemented stroke care across Canada. Manny will follow with how important the policy and advocacy components have been to contribute to this work. Systems change takes a village. There are many layers we have to work with, and it's not just one group or one particular area. So we work across the leadership, we have to understand the environment, we have to work closely with organizations and clinicians, as well as individuals who are experiencing stroke, their families and caregivers. Through collaboration with all of these groups and at different levels, over 10 years, we've been able to actually affect major system change. What you see here is the groups in Canada who were early adopters to putting in integrated stroke systems through all of our levers were able to actually significantly reduce mortality compared to the groups who were slower and longer at putting in changes. What's really important in all of our work is we've been working closely with people who have experience. In order to provide individualized patient-centered care, we have to understand from their perspective. With the COVID pandemic, that has changed stroke care around the world, and we have quickly responded both with clinicians and providing interim guidance, with creating tools and with reaching out to understand the needs of our people with lived experience. This slide shows you some of the results of a recent survey. As everybody in the world's experienced, there's been great delays in showing up in hospital with symptoms of stroke. So we put on major campaigns to increase that public awareness that even in a pandemic, stroke's still an emergency. People with lived experience are really struggling during these times with managing medication, understanding how to care for themselves in their current condition, and how to do rehab, because we know that much of the inpatient and outpatient rehabilitation can greatly reduce. As I mentioned earlier, virtual care is something that has switched everywhere. So we've created tools to help support people with lived experience in managing an effective and efficient virtual care appointment. These tools can be found on our website. As well, we have similar tools for clinicians. Most importantly is, as I've mentioned, are people with lived experience. They have a lot of mental health, emotional, and support needs, and we have provided online communities of survivors and caregivers that they can go to for safe space to work with each other and collaborate and talk to each other and learn. We encourage all people to make these websites available and aware to their patients so that they can seek them out. I'm now going to turn it over to my colleague Manuel, who's going to talk to you more about the policy and advocacy side of our work. Thank you.
Thank you very much, Patty. So on slide 12, you'll see the list of issues that Heart and Stroke currently advocates for. Highlighted in red are the issues that are most relevant to stroke, and I'll be speaking about these issues today very briefly. But the first issue is the funding of our Fast Signs of Stroke campaigns. Heart and Stroke has been focused on seeking provincial government support and funding for these campaigns across the country. Over the past year, 6 provinces were able to launch FAST campaigns with government support in Canada. These campaigns are advertised in a variety of milieu, including public transportation vehicles, ambulances, etc. You can see an image of the campaign on an ambulance here on this slide. So what we have learned from these campaigns through pre and post campaign evaluations is that those who saw the ads are almost 3 times more likely to correctly identify all 3 key signs of stroke. We also know that provinces with sustained funding, such as British Columbia, are able to maintain these public education awareness gains. British Columbia has been in the market since 2015 with this campaign. The next issue I'll briefly speak to is universal pharmacare. Our federal government committed in the 2019 federal budget, in the 2019 federal election, and most recently in the speech from the throne to implement pharmacare. They indicated that they are keen to work with provinces and territories willing to move forward without delay. We need national pharmacare in Canada. We have 7.5 million people who have either no coverage or inadequate drug coverage. We also know that 16% of people in Canada went without medication for heart disease, cholesterol, or hypertension because of cost. We have the 3rd highest drug costs in the world. And over 1/3 of people in Canada report financial household stress due to prescription drug costs. Canada is the only country in the world with a universal healthcare system that doesn't have a universal pharmacare system, coverage of drugs outside of hospitals. Also, we lack purchasing power. The reason for this is because we have 100 public and over 100,000 private drug plans. This leads to very high drug costs. It's been estimated that we would save billions of dollars in Canada if we implemented a national pharmacare program. Pharmacare is more urgent than ever as a result of the pandemic. We've lost millions of jobs here in Canada because of the pandemic, and as a result, an increased likelihood of loss of employer-provided drug coverage. In fact, over the past year, Canadians were twice as likely to have lost prescription drug coverage than to have gained it. We also know that pandemic-related unemployment has disproportionately impacted women, recent immigrants, and racialized persons. Thus, there's an important equity angle to implementing pharmacare. We're asking that the federal government consult with provinces and territories to develop a preliminary common formulary of essential medicines by January 2022. We're also asking in the federal budget, the next one of 2021, that the federal government support the implementation of pharmacare among those provinces that are willing to participate. Final issue is nutrition. In Canada, we know that 90% of food and beverage products advertised to kids are unhealthy. We also know that Canadians are getting half of their daily calories from ultra-processed foods, and that's as high as 60% among kids 9 to 13 years of age. So these are the driving factors behind the creation of Canada's healthy eating strategy, developed by the federal government. It has 4 pillars. 2 were recently accomplished. A ban on trans fats was implemented in 2018, and a new revised Canada Food Guide, similar to the Brazilian Food Guide, was implemented and announced in 2019. There are 2 measures outstanding: front of package nutrition labeling, and you'll see examples of symbols on the right here that will be used. And as well as the other measure that's outstanding is the introduction of food and beverage marketing restrictions to kids. So we're asking that the federal government finalize front of package nutritional labeling regulations. They're almost done. Just need to get across the finish line and to introduce legislation to restrict food and beverage marketing to kids. Thank you.
Thank you all very much for joining us today. At the end of this session, we'll be happy to take your questions along with our colleagues doing other presentations. Thank you very much.
Well, thank you so much for inviting me today. So my name is Elizabeth Suka. I work with the Economist Intelligence Unit, which is part of the Economist Group. And we've been working on a bit of research here for the BMS Pfizer Stroke Alliance. So we conducted research on how 5 countries perceive and act on their policy and investment decisions around stroke prevention. We did extensive desk research. We interviewed experts. We surveyed over 250 policymakers, payers, healthcare professionals, and we focused on 4 countries, as you can see: France, Germany, Italy, Spain, and the UK. This was independent research. One thing, if anything, this captures the views before the pandemic, and if anything, stroke outcomes are probably going to be worse as a result of the pandemic. Namely, we know that there are lower A&E attendance rates. Lockdown has probably affected healthy lifestyles, and people are not seeking possibly preventative support early on and treatment as well. So here we have a map of Europe, which kind of looks at the kind of incidence and deaths. So, good news here, just there's been rapid, rates of decline of stroke rates, but despite these rapid reductions in stroke in Europe, demographic changes, namely an aging population, mean absolute number of stroke incidences on the rise. So, most strokes are preventable, and the high healthcare costs can be significantly reduced with more effective policy response and public investment in further prevention activities. As you know, indirect costs are very high. Many people survive their first stroke, but about 1/3 suffer a disability. Our survey showed only 40% of respondents felt indirect and direct costs of stroke to economies is well understood by the public. And this view was held most strongly by the policymakers, payers camp around 49%, and patient groups at 43%, compared with healthcare professionals only 29%. Significantly, 84% of our respondents agreed that more investment in prevention now will help reduce healthcare system costs in the long term. Right, so priorities for investment. So we asked our respondents to rank how they believe their government prioritizes funding across 4 buckets, namely stroke prevention, stroke management in primary care, stroke management in secondary care, and rehabilitation. And as you can see here, overwhelmingly, they thought governments prioritize stroke prevention. In a distant second with stroke management in primary care. And this pattern was seen across all 5 countries, with those in France in particular seeing stroke prevention as a #1 priority. However, more work will be needed to improve regional disparities as more negative stroke outcomes are among the poorer and deprived populations. For example, in England alone, the most deprived areas are almost 4 times as likely to die prematurely from CVD disease compared to those living in least deprived areas. So there's a real need for equitable distribution of care and resources, greater government support, along with better implementation of guidelines. Right, so let's have a look at education and awareness. Our research found that there was a general alignment actually between current funding priorities and the priorities of respondents around modifiable and other stroke risk factors. However, the largest disparity, so as you can see here, the second kind of line here, was around healthy lifestyle and living. That's, weight management and exercise, where many more respondents say there should be greater priority by government. So, people listening today are working in advocacy, so this is something to ponder on. Our research also found education and awareness initiatives need greater funding and support from government. So there are many effective campaigns like Know Your Cholesterol, Know Your Pulse, and they will become even more important in the future. But such campaigns are largely funded privately and insufficiently. And to make a wider impact, more government funding is necessary. So let's look at clinical guideline adherence. Now, which, clinical guidelines are hugely important as a framework to help, check the quality of stroke care, but they're not always consistently applied. So when we looked at this by our groups, 73% of those surveyed thought cardiologists, the experts, entirely or mostly followed clinical guidelines, followed by the primary care doctors and nurses. Only 32% thought that payers were entirely or mostly following guidelines. And I do wonder if you're surprised by that or not. But interestingly, this tracks really well when the data is crossed by that very subset. Only 31% of payer respondents say that payers entirely or mostly adhere. As for the barriers to adherence to guidelines, well, nearly 1 in 3 respondents believe that a lack of funding from national authorities, and 23% point to lack of funding from regional authorities. So clearly, clinical guideline implementation has to be dramatically improved. And we also looked at digital tools, which are, hugely popular now, like apps and smartwatches. They're increasingly being used. Only 20% of healthcare professionals say they have not recommended them to patients. And as you can see from here, the most popular apps are for healthy diet and healthy lifestyle. Most respondents, so 71%, say they provide them with useful data to help them support people. And most experts feel governments have a growing role to play in this area, in regulation and encouraging their uptake for stroke prevention. And let's have a look at roles. So we asked respondents who they felt should play the biggest role in supporting stroke prevention. Most agreed that GPs, followed by specialists like neurologists and cardiologists, then nurses should have the biggest role. So as we know, GPs play a huge role in patient checkups, in blood pressure monitoring, and managing long-term risks. Nurses, we know, could play a much bigger role too, providing advice on lifestyle changes. As we know, primary healthcare is very overwhelmed at the moment. It actually was really surprising to see how poorly pharmacists fared here, where 2% chose this group. Now, they are the most accessible healthcare professional on the high street and can be positioned for population screening. Patient groups as well were generally overlooked as potentially more active players, which brings into question if the most on-the-ground stakeholders are being fully used. This, again, for the advocacy groups listening in today, it's something to consider for your advocacy work. So my last slide here. So I do encourage you to read the report. In conclusion, our investment strategies to improve stroke prevention, we recommend consider more funding, to improve public awareness of the stroke risk factors. And some of them are really, quite obvious things, and we just need more action in that area. Empower and, these underutilized healthcare professionals like nurses and pharmacists. We also need more evidence around the cost effectiveness around prevention. And, once we know which ones work the best, that will help, get buy-in from government and other stakeholders. We also need to ensure there's sufficient funding to support the uptake of the clinical guidelines. There's no point writing them if no one reads them and acts on them. And then finally, this huge shift now in preventative consumer technologies. These need to be funded, supported, and also regulated properly. So, yeah, that's pretty much it. And my last slide actually is here, the link to the report. So I do hope you get a chance to read it. And I look forward to the discussion today. Thank you.
Hi, my name is Arlene Wilkie. I am the Director General of the Stroke Alliance for Europe. I'd like to thank the World Stroke Organisation Stroke Support Organisations Forum for inviting me to talk today, where I will tell you about the economic impact of stroke in Europe research that we did and how we will use this information in our advocacy work. So I'd like to say hello to everybody. I'd like to tell you about why we did this work, how we created evidence, how we are using the evidence to increase impact and drive change, and hopefully give you some hints and tips on the way. So why did we do a cost of stroke study? What we know is that over the coming years, there will be a rise in the ageing population, a rise in the conditions that increase the risk of stroke. And we know from the Burden of Stroke report that SAFE published a few years ago that the cost of stroke will increase. However, what we don't know is what the full costs of stroke are. So the healthcare costs, plus the social care costs, plus the informal unpaid care, i.e. the families caring for stroke survivors. And we also didn't know about the financial losses due to people not being able to work. And finally, we didn't know what the impact on these costs would be if we invested in stroke care. So we decided we needed to carry out research which would give us a clear understanding of the current and future economic, societal and social costs of stroke, the impact of investment in stroke services, to help us develop a robust case to bring the issues of stroke and its costs to those with power to improve the lives of stroke survivors. We know that money talks. But our goal for all of this work is to gain support for improved stroke services by those in power equally across Europe. So what did we do? We needed to raise money to fund this research. So we created a funding proposal for sponsors, and we gained 4 sponsors to fund this research. We put together a tender document because we needed to ask experts to do this research for us, and we asked research institutes to submit proposals. We awarded a 3-year grant to the Health Economics Research Centre at the University of Oxford. And I'm really pleased to let you know that the results will be published on the 9th of November. So I'm not able to give you the full results of the research project. However, what I can tell you is that if things stay as they are, the number of people living with stroke is projected to increase. The cost of stroke is projected to increase alongside this. However, our research was able to show that if we do include some stroke interventions in stroke care, we can reduce the burden of stroke. Overall, we showed that interventions increase outcomes for patients and stroke survivors. Interventions tend to generate cost savings, and they're generally good value for money for all countries involved in the research. So in summary, we were able to show that while stroke is an increasing cause for concern, it is a viable investment proposition, which is music to our policymakers' ears. So what did we do with the results to help us build our advocacy work? We had to bring a group of people together to help us turn this complex data into lay language. None of us at SAFE are economic experts, so we needed to bring this group of people together. We also reviewed the current landscape. This was really important to ensure that the research and the results and the findings that we were publishing were relevant in 2020. And we had to review COVID and its impact on stroke care, and we have referenced that in our document as well. So it's important to keep your information relevant. We pulled out one key message, and calls to action. This helps us for consistency across Europe. We communicated regularly with our funders and our members. It's really important to keep them in the loop so that they will help you promote your work once it's all published. We asked our members what they needed to support their advocacy work. And this has resulted in a series of documents that we have circulated to our members to use on launch day on the 9th of November. We've produced a 3-page lay summary. We produced a 40-page research report in lay terms, and we then have a much longer research report. So these 3 documents mean that different people are receiving the information depending on whether they want the more complex information or the more lay information. We also produced key messages and calls to action. These are really important so that all our members across Europe are using the same information so that we have a consistent message that we're giving across Europe to our policymakers. We produced a how to use the information in your country document because the research gives each country information on stroke numbers and care in their country. And this will highlight different things to different countries. So we needed to give our members advice as to how to use this and interpret it within their country. We also produced a social media template as well as press releases. This will allow our members to use these to translate them into their own languages and use them in their countries as they see fit. And we also produce some infographics to make things, to bring things to life and to make things look bright and cheery. And SAFE will use this data for the basis of all our policy and advocacy work moving forward. So you'll want to know what the successes of our advocacy work have been so far. In terms of achieving our goal, it's too early to say as yet, as we are only going to be launching the results next week, but please watch this space. As our calls to action are clear and measurable, we are calling for policymakers and health planners to act now to improve outcomes and reduce the burden of stroke in Europe. Our calls to action for countries specifically and at that EU level are very similar. We are looking for countries to adopt and implement a national stroke plan. We want investment in prevention, service provision and research. And we're asking for data to be collected in countries so that we can see where systems are improving and maybe where things need to be improved even further. And then specifically at the EU level, so at this higher level, we are calling for the creation of a stroke-specific subgroup to help inform and shape stroke policy at that very top level, EU level. And finally, just some hints and tips about using this complex information for advocacy. Before you start, define and understand the problem you're trying to highlight. Try and be unique. Try and do pieces of work that haven't been done before. Plan out what you can do with the resources you have. So if you need funding, find a funder. If you need someone to do the research, find someone qualified. And if you need a group of people to help support you analyse and understand the results, find that group. Once you've done this and you have the research, create a strong, compelling message. It's really important to be able to present the problems and the solution. Policymakers will not know how to solve the problems of stroke. If they did, they would have done that already. They will look to you for the solutions. So do think those through when you're developing your advocacy work. Work with your members and create documents that are relevant to them. This will engage them and this will mean that they are working with you and sharing the research that you have created. Be creative with your communications. Do what you can. There's lots and lots of digital channels that we can all use just now to promote our our messages, be creative. And finally, plan out in advance how you will measure success. Use and review your data. Please don't let your data be your report that just gathers dust on a shelf. Thank you for listening, and if you have any questions, please don't hesitate to contact me.
So wonderful to hear from all of you, and it's amazing the perspectives that I myself got from such varied personalities across the world, and you've done such amount of work. We have a lot of questions coming in, so I'll just rush it. Chess, my first question is for you. In fact, you've done such amazing work in very resource limited constraint settings, and I was just wondering, how did you do it? How do you combine your stroke registry? How did you get into the community engagement, and how are you so successful? Can you give us some tips there?
Yeah, so I think a key, as a starting point, a key to our success has been that we haven't viewed community engagement as just a means to an end. And it's reflected in our approach in the setup of the program. So in the setup phase, we held an initial community consultation meeting with stroke survivors and caregivers, and I think we viewed them as the core of the expertise that we needed to kind of tune in with and engage with to help drive our policy advocacy. And in doing that meeting, initially it was a service user reference group, and the intention was for them to have input on the research agenda and processes. But beyond that, and beyond performative justifications, we were aiming to build local capacity to continue the legacy of this CISL program. So like beyond the funding life cycle, I think that's a really important element of ensuring sustainable impact. And so with that sort of ethos, and I have to acknowledge and accredit Professor Chris McKevitt for that sort of ethos. He's the lead of the work package, and an outcome of that was that consultation meeting sort of evolved, and the stroke survivors and caregivers, they enjoyed it so much because we left the agenda very flexible. They enjoyed it so much that they actually asked us if they could meet more regularly, and from that, moving forward, 18 months later, we now have the beginnings of a stroke support organization, which will be the first of its kind. So I think that's really a huge success, and they have driven the creativity of our communication. They've helped signpost stigma around stroke, that unforeseen stigma around stroke in Sierra Leone. And that's really helped us to tailor our approach and make sure that things really do align with local priorities and needs.
Most people talk about getting data and then using data to influence policymakers. Do you think getting that data also helps you in community engagement in some ways?
Absolutely. I think data and community engagement are extremely important combined. And these meetings that we've been having with the stroke survivors, we've been engaging with them and updating them on data. And bear in mind that especially in resource limited settings where there's variable education levels and literacy levels, it's a long scenic route in getting towards that sort of level where you have an educated or informed survivor group. I mean, a lot of our stroke survivors didn't know what stroke was even after receiving their treatment and being discharged and even going through the rehabilitation process. So we have used the data, we've sort of bounced them off each other. It's been a very iterative process, and I think the learnings that we'll capture in the retrospective evaluation will really be useful and sort of contribute to the wider discussion. And I know a lot of amazing work's going on. Listening to Rita's earlier discussion, I know there's a movement towards this in sub-Saharan Africa, and we're really delighted to be a part of that.
That's wonderful. One thing I noticed in your presentation was talking about religious leaders, and that kind of brings into perspective how stroke advocates need to take into consideration all the cultural things that we probably might ignore when we are going about our work.
Absolutely. And I think that became very clear at the first consultation meeting. There was the conversations were really grounded in religious belief and cultural belief. And it's very tempting to view that as a barrier, but I think what we've done is we've tried to view it as an enabler and an opportunity to engage. There's been a lot of organic developments that have come out just from handing the baton to the stroke survivors and caregivers and allowing them and giving them that creative flexibility to co-develop engagement activities. Yeah.
So I think all the other speakers come from a perspective of a first world, and where you have very nice data is collected there. You have guidelines, and there was this mention about why guidelines are not really implemented and what are the barriers to guidelines implementation. And I'd like to direct this question to Dr. Patrice Lindsay. What do you have to say about that?
Thanks very much. Guideline implementation is a major problem. We know that only about 16% of all guideline recommendations that we publish actually get implemented. One of the issues that we tried to address when we did the World Stroke Guidelines is a recognition that not every center has the infrastructure and the actual resources to deliver those guidelines the way that they're defined. So within the World Stroke Guidelines, we specifically created categories for each of the recommendations we included on who we thought it was reasonable to be able to implement those. And I think that recognition that, do the best with what you can, be aware of kind of what that next level is and be striving to get there, but also being okay that you can't be there right now. So I think with a lot of guidelines, especially, outside, as you said, of the high-income countries, people really struggle with just not having the resources to do them. And not having the expertise, so the resources in terms of human capacity, expertise, the equipment. Like it's great for us to say, for rehab, use all these fancy equipment and tools, but many people don't have access to those. The same with CT scanners. And so I think there has to be a real good assessment of what you can do and what's realistic to strive to do as a next level. And that's what we found is the biggest challenge. I've worked with countries all over the world to help them implement guidelines, and that's where it comes down to is the will is there, the spirit is there, people want to deliver the best care possible, but sometimes there's just big obstacles in their way that aren't within their own control.
I have a question from Dr. Ranganathan, who's from India, and he's mentioned that the biggest problem, in fact, stems from the ground. We don't have enough awareness about stroke. And is it worthwhile, raising awareness beyond the usual acronym, the FAST acronym that we've been using? Because he mentions, people don't really know that sensory symptoms can be stroke, dizziness can be stroke, and we have the BFAST and some other acronyms coming in. And what are your thoughts on that, Dr. Patrice?
So we run into this all the time. We have people who write into Heart and Stroke and say, you posted these symptoms, but my symptoms were this. So on our website, we do have the extended symptoms. The reason FAST has been universally accepted is because we know the vast majority of strokes will display one of those signs. And that if you're showing any of those signs, it's far more likely you're having a stroke than another mimic kind of event happening. So those are the most sensitive for stroke. It's not saying the other ones don't exist, and anybody who stroke support organizations should be advertising those others. But FAST has really been proven with evidence to be effective in getting those people who are having, very defined strokes to the care they need faster. And
so it really ties into the idea that keep things simple, I guess.
Yeah. BFAST is a great addition, but beyond that, to add the other pieces gets really complicated.
You mentioned that you've been quite successful in Canada with the food guides, and that's quite interesting. I just wanted to know who exactly worked on that. Was it only the stroke advocates, or did you kind of pull in the cardiologists, pull in some other public health individuals? How did you go about that?
So we're part of a food coalition, so a healthy nutrition coalition that involved other advocate groups, such as ourselves, so from across Canada, so different groups in the cardiovascular space, Obesity Canada, many other healthy eating and primary promotion groups, researchers, as well as government. So it was a true collaboration and coalition among several groups.
A lot of hard work must have gone in there. And do you think PR skills are very essential to get that kind of work done?
Sorry, I couldn't hear you.
Public relations skills, how important do you think they are for all the stroke advocates here?
Oh, they're critical. Yeah,
Critical.
it's really people working together at all from all angles. And maybe some of our other speakers, maybe Arlene can speak to that from SAFE as well.
Yeah, Arlene. So, what do you have to say about the PR skills?
Yes, thanks for bringing me in. Yeah, I think it's really important that that we have patients at the heart of all of this, and that they're trained and they're given the key skills how to do this. It's not easy being an advocate. It's not easy being a stroke survivor. It's not easy being an advocate. So yeah, having that good backing from your stroke support organisation is absolutely vital and key to get this job done.
Your report is really very impressive. You put in a lot of effort in the report. What are the things that surprised you when you gathered that data and you put it all together?
The biggest surprise was, and this might not be a surprise to many of you, but it was actually the costs of the informal care. The total cost, the informal care was around 27%. And that is a lot of free time, let's say, free money that people are contributing to society. So what this shows is that for our governments and for our policymakers, there's a huge burden on carers and families and friends and neighbours in the support of stroke survivors. And I'm hoping that this report will be able to be used by countries to actually demonstrate the life after stroke element and that element of support that families give. A quarter of all costs. I was really quite shocked at that.
In fact, this is one of the questions one of our viewers, Urvashi from Mauritius, in fact, she brought up this point that quality of life after stroke is something that most policymakers and most advocates may not be really factoring into their work plans. And it's interesting you bring in the informal cost, because I come from India, and some of the rehab programs are now looking at how to get family members involved in the rehab process, and it's just free labor, for example, and nobody's covering it. And I wonder what Jess has to say about it. Jess?
Yeah, it's definitely that resonates with this, what I know of the Sierra Leone context. A large burden of costs are borne by families, and care. Often families come into the hospital and provide care at the bedside as well, and all that's not factored in. The CISL program are working on quality of life measures, and working towards a translation of the EQ5D, and so there's great progress with that. But yeah, I think it's a really important thing to sort of consider, and it varies greatly across different contexts, for sure.
There is something called the Stroke Action Plan for Europe, which might be something people might want to look at, because within that there are 2 chapters in there specifically on rehabilitation and life after stroke. And this is something that SAFE and our European friends are going to be using quite heavily over the coming years to try and implement national stroke strategies across Europe. So it just might give people some hints and tips as to what to include in their plans from a rehab and life after stroke point of view.
Arlene, you also talked about, how you're going to be using all the data that you've collected. I'm just wondering, you've done such amazing amount of work there. Are you looking at collaborations with low middle income countries or groups working there and doing the same, replicating this kind of work there?
So we would welcome if anybody wants to talk to us about how we did the research. Our research covered 32 countries in Europe. So it covered all the EU countries as well as 4 additional ones outside the EU, including the UK. So it did cover a kind of our east or west and maybe more wealthy, less wealthy countries. So we did that across Europe. But if anybody did want to talk to me about how we did this, I'd be more than happy to talk to people about it.
That's great. I think some of our audience members may be interested there. Liz, you've done a lot of research as well. And what really struck me from your data was that it really boils down to very simple things like a healthy diet and, just education and awareness, which seem to be lacking, or at least people think not enough is being done there. Did that surprise you? Did that finding surprise you? I mean, you're working in a first world country again.
Yeah, so obviously this report was on 5 countries in Europe, and you think, oh, okay, so it's these 5 European countries, they surely have got their act together, but there is so much burden still. There's right here, the readmission from stroke is really high still, and it's what's surprising is like there's such easy messages around, reduce your blood pressure, healthy living, and yet people are not acting on it. And hopefully one of the key themes in our report, as we know, in low resource and countries, they rely on community health workers. Well, what about in our rich countries? Who can you rely on? Well, we were surprised to find out, like around pharmacists, how few of our respondents thought about them as potential population screening for atrial fibrillation and how they can support. Because if you think about it, the footfall for pharmacies in Europe is so high. 20 million people will visit a pharmacy in Europe every day. And while you collect your medicine, get your pulse checked, maybe your blood pressure. And so, primary care is really overburdened, isn't it? And so why not use the wider healthcare workforce to tackle these really quite easy and simple messages around the risk factors? And we know, preventing stroke is going to be so much better than having to spend all that money on those direct costs, on the rehabilitation. The long-term costs are very high. So yeah, prevention is hugely important.
And I'll just jump in there, another group, pharmacists are critically important in Canada. We work very closely with it. Another group that's emerging is the ambulance EMS specialists, the emergency medical services paramedics. They are well-trained individuals. And in North America, they have formed a group called Community Paramedicine. And they've been doing a lot of the prevention wellness checks, following up on people with diabetes and high blood pressure, especially high risk groups such as seniors. And that's really a huge, huge help to take a bit of the burden off other parts of the continuum. So people have to be creative about which other professionals are out there and non-professionals who can actually participate in these kind of wellness events.
I was just going to add, also, we were really surprised in our survey, patient advocacy groups, how low they were very rarely chosen. Only 2% chose them as having a big role in this. And we were completely surprised by that. And we know a lot of these public awareness campaigns, which boost health literacy around this area, is what you really need. So, that's really important that we work more closely with government and health authorities, because the messaging is not getting through clearly.
So do you think it has something to do with visibility? And how do you think we can increase visibility?
Yes, I think health literacy around the stroke risk factors is an area that needs to be worked on, definitely, because it's just really surprising, like from our survey results, like how many people didn't realize, it is a major cause of disability. So that it's such a burden on society. And you'd imagine that, just these simple messages need to be out there. So yeah, bigger campaigns, be it TV, radio, they need to be, people need to think about them again. They need to reintroduce them, really.
How do you think, this is a question for everyone, in fact, now that we're connected, we're talking on Zoom and everyone has a phone, how do you think social media can be leveraged upon to increase advocacy activities, to influence policies? And maybe I'll take it all around. So let's start with Jess. Jess, how about you? What are your thoughts on that?
Yeah, I think social media is a great platform. Obviously, it brings, in an LMIC context, it does come with its own caveats in terms of, accessibility. But you'd be surprised at how many people do have access to smartphones. And actually, during the COVID pandemic, it kind of stalled our in-person engagement activities. So we moved a lot of it onto WhatsApp, and that's proven to be really interesting and useful in maintaining communication and sharing awareness videos. And so I think social media is definitely something that's got a lot of opportunities for future expansions of policy advocacy efforts.
Dr. Patrice, do you use social media in Canada to promote your activities?
We certainly do. We have, within Heart and Stroke Canada, we have Twitter, we use Facebook. We have 2 online communities of people with lived experience who can come together within Facebook and share with each other and find support, and that's been hugely successful. So social media definitely has a role. It can't be the only role. We need to have a multi-pronged strategy. But as we move forward and I think the thing the pandemic has taught us is we need new ways of communicating, and that, you know, we've all survived the last 6 months not being face to face with people. And so we need to now build on that, but also to put some good infrastructure in place, because we all kind of moved to virtual and social, but not necessarily with a good plan in place. And now it's time to kind of take a few minutes to put that plan in place so that we're much more efficient and have a better reach going forward.
Definitely. And Arlene, what is your take on that? You collect data. Do you think this data can be actually broadcast on social media just to get people involved?
Oh, completely. One of the things that we'll be doing on Monday, hopefully lots of you will follow us and support us on this. We'll be doing a lot on Twitter and social media. And what I would, one of our learnings is try and bring things to life. Part of the challenge of data and advocacy, it can be a bit dry, it can be a little bit, you know, it's charts, it's graphs, it's numbers, but how do you make it interesting? And so we've done quite a lot with infographics. So we're trying to do, so trying to use words as well as infographics. And one of the things that I'd like to do, if I was to do this again, but we should do more of this moving forward, little short interviews, little short snippets. So we could do quick interviews with the researchers, do quick interviews with patients and stroke survivors. Everyone, as I just said, has a smartphone. You know, we can do 15-second recordings, and we can promote. You can bring data to life. This is the great thing about digital communication and social media is there's a huge platform to do things a little bit differently, and it just doesn't have to be figures and numbers we can put out. It can be colourful infographics, it can be people stories, and these actually don't cost that much, especially little videos. You can just record it and put it out there. Be creative and think about how to get your message out there is what I would say. The world is your oyster.
True that. Liz, you come from the media. How do you think we can best leverage the media?
That's a good question, and I agree with a lot of the other speakers. And social media is a huge platform, and we need to use it because that's where a lot of people are. But I think with stroke, I mean, people hear the word stroke and they think, oh, that's not me. But when you start talking, it's just changing the conversation. Maybe it's about these are the risk factors and needing to connect the dots with brain health. And then people think, oh, that might relate to me, actually. But when you think stroke, they go, old person, it's not me. And our survey showed that a lot of people thought that, you know, it's something that affects older people, not, you know, middle-aged people. And so I think it's maybe the word, maybe need to talk about it, like how else can we get a more broader conversation about what stroke means. But I think that would really help as well. But there are great stories out there all the time. I mean, Maradona just had surgery recently, didn't he? on some stroke. So the people are interested in this, and you know, there's a lot of celebrities who've had stroke and they talk about it. So, you know, it is out there, thankfully.
You know, I really dream of a world where we don't need celebrities, and our stroke support organizations are the celebrities, in fact, and they do, you know, they do such great work. We really need to do much more to bring them into prominence. Because we're going to be finishing soon, I have two questions, and I'm going to direct them to all of you in turn. And my two questions are, what is the biggest challenge you faced in your advocacy work? And the second part of the question is, what next in your work? So let's start with Liz.
Right. I mean, so, you know, obviously I'm in the media, and, you know, the challenges around advocacy work, I suppose it comes down to, you know, having a simple message so there's a call to action. And any of our reports, we always try and, as Arlene mentioned, infographics, easy to digest information, making it more simpler. So I suppose that is a challenge, talking about complex things, but making it really translatable to a general public.
Arlene, what about you?
I think the biggest challenge that we face, and I'll talk from a stroke point of view, is, I'm going to say competition, and I don't really mean competition, but I mean the noise of other health conditions. So we have, of course, we've got COVID just now. In a non-COVID world, we would have had diabetes, cancer, heart disease as big issues that politicians face and focus on, and dementia, I suppose, is another one. So it's about how we bring stroke into that narrative. Stroke needs its priority, but it needs to be brought into that conversation. And I think in this COVID world, we can talk about, we need to focus on non-infectious, which is great, but we also must focus on non-communicable diseases, of which stroke is a key one. So we must make, that was part of my presentation, was make stroke relevant, make it relevant with the stats, with the data, and with patient experience and those stories to bring it to life. Don't let other conditions put you off from what you're doing. Stroke, we must bring stroke to life, so keep on doing it. And I love what Jess has done. I love that experience of, you know, from going from nowhere to having nothing, to have done all that awareness, to now have something. It's just a fantastic, it's a fantastic example of how you can do it. Don't let things put you off. Keep going, keep going. What are we doing next? For SAFE, we want to work with our members to do more to get that message out there. We want to take this information, work with the Stroke Action Plan for Europe Implementation Committee to get this done. We wanted to support our advocacy work. We want to do more at the EU level. We want to do more for European Stroke Awareness Day. There is so much that this data is now going to help us almost springboard in our work. So I'm very excited about it.
Dr. Patrice, how about you?
Thank you. So I was actually, my comment was going to be similar to Arlene's, that there is a lot of competition, but what we've, you know, and so the challenge is picking the right moment and the right topic. So in the, like, for example, in this current environment where everybody's worried about the pandemic and COVID, we know that people with stroke are at much higher risk. So change your context and, you know, as Elizabeth and others said, write your story to the other contexts around you. So still promote the stroke message, but put it in the context of, you know, with COVID, people with stroke are 3 times higher risk of dying if they catch the condition. So it's the challenge is finding the right angle in so that you can continue, as others said, to make stroke relevant when all this other things are happening. The other piece is the partnership. So we have launched a campaign around the heart-brain connection to, again, kind of elevate the importance of stroke, because stroke leads potentially to dementia. And because everyone has very attuned to cognitive impairment and dementia, again, it's finding those right sweet spots. So what's next for us in the next year is continuing to promote that idea of the heart-brain connection and the impact of stroke within that and cognitive impairment, as well as working within Canada and elsewhere to help build that infrastructure for virtual care. And we're building a framework now to help people understand, you know, their decision-making process of when virtual care is appropriate and when it's not.
How about you, Jess?
Yeah, so I think it's really the same thing, different context, but similar challenge, and that is competing health priorities. I think it's even more pertinent in LMICs where you have high burdens of infectious diseases, and now we have COVID as well, you know, on top of that. So I think it's competing health priorities paired with limited national resources, but there are silver linings in those circumstances, and I think it's really the individual, you know, PR and then communication channels and luck. I think luck is a huge part to do with it, and also pre-existing relationships, which we do have through KSLP. And so, you know, there's challenges, but I think with all these challenges, if you look around them, then there tends to be unforeseen opportunities as well. In terms of what's next, obviously analysing and publishing the CISL research data, continuing engaging with the stroke survivors and supporting them in registering as a stroke support organisation. So they've expressed an interest in doing that. And so we're going to work closely with Sarah Balson and the World Stroke Organisation in doing that. And that will serve as a great legacy for the CISL programme beyond its funding life cycle. And thirdly, engaging with the newly formed African Stroke Organisation. It's really exciting work going ahead at the moment, and sort of sharing learnings with other professionals and stroke survivors and caregivers, and exploring the potential for future collaborations. Yeah,
it seems collaboration is key, isn't it? We can't keep working in silos. And I have to say thank you to Sarah, because she's given me this opportunity to hear from all of you fabulous speakers. So much learning to do. And I'm going to hand over to Sarah.
I just want to close by saying thank you to all of our speakers today. I really hope that our audience gained a lot from this first WSO Members Forum. We heard so much about collaboration, in stroke advocacy in different contexts. Also heard from a very diverse group of speakers around understanding how to increase the impact of our advocacy. And we would love to continue to do these members forums at WSO. I've recorded this session, so we will circulate that. And that's it from me. Thank you again. Have a good rest of your day or evening, everybody, and really thank you for joining.